The human small intestine is a highly specialized absorptive tract. It measures anywhere between 300 and 850 centimeters and spans the entire distance from the duodenojejunal flexure down to the ileocecal valve. Functionally, we divide this continuous tube into two segments. The proximal 40% forms the jejunum, and the remaining 60% makes up the ileum. This cross-section shows the internal architecture of both. The jejunum handles the majority of nutrient and fluid absorption. To support this, it relies on a wider diameter, a thicker wall, and dense prominent mucosal folds, known as valvulae conniventes. The ileum, by contrast, has smoother walls and a thicker, fattier mesentery. It also acts as an immunological center. Notice the large aggregates of lymphoid tissue, Peyer's patches, embedded directly in the distal mucosal wall. The terminal end of the ileum also possesses exclusive cellular transporters. It is the only site in the body capable of absorbing vitamin B12 and bile salts. Because these structural adaptations are highly localized, surgical removal of a specific segment carries exact, predictable physiological deficits. This massive absorptive surface requires an equally massive blood supply. This diagram traces the superior mesenteric artery, or SMA, branching directly off the aorta to serve as the exclusive arterial feed for the entire midgut. A dense network of sympathetic nerve fibers from the splanchnic nerves tracks directly alongside it. Notice how the arterial arcades change, moving from simple loops in the jejunum to highly complex, multi-tiered networks in the ileum. The venous drainage mirrors this map. The superior mesenteric vein collects the absorbed nutrients and carries them directly into the portal system for processing by the liver. This localized vascular design is highly efficient for nutrient transport, but it places the entire bowel at risk. Complete reliance on the single trunk of the SMA creates a distinct anatomical bottleneck. If an embolus from a fibrillating atrium lodges in the middle colic artery, or a thrombosis forms over an atherosclerotic plaque, arterial flow is completely severed. This is acute mesenteric ischemia. The resulting tissue death follows a strict, rapid timeline. Following complete occlusion, the bowel wall drains of blood, becomes cyanotic, and progresses to irreversible full-thickness infarction in under 6 hours. The clinical presentation is highly distinct. Patients experience sudden, severe central abdominal pain, yet their abdomen remains soft and largely non-tender on palpation. The pain is completely out of proportion to the physical exam. Time is the critical variable. Diagnosis requires immediate contrast CT imaging to locate the occlusion, and a serum lactate draw to measure the extent of tissue hypoperfusion. Survival depends on an emergent laparotomy. The surgeon must open the abdomen to immediately revascularize the SMA or resect the segment of bowel that has already died. The primary enemy in this operation is the ticking clock. Once necrosis sets in, the damage is permanent. Beyond vascular emergencies, surgeons must navigate congenital structural anomalies. Meckel's diverticulum is a persistent pouch of tissue left over from the embryonic vitello-intestinal duct. We identify its frequency and location using the rule of twos. It occurs in 2% of the population, measures roughly 2 inches long, and sits exactly 2 feet proximal to the ileocecal valve. The clinical risk comes from its cellular makeup. Approximately 20% of these diverticula contain heterotopic epithelium, pockets of ectopic gastric or pancreatic tissue growing where they do not belong. If the pouch contains ectopic gastric mucosa, it secretes acid directly into the alkaline small bowel. This causes local peptic ulceration, presenting as painless lower gastrointestinal bleeding. The pouch can also become inflamed. Because it is midgut in origin, Meckel's diverticulitis causes periumbilical referred pain that perfectly mimics the acute appendicitis. This creates an absolute rule for the operating room. If a surgeon explores an abdomen for suspected appendicitis and finds a completely normal appendix, they must systematically run the distal small bowel to locate a hidden inflamed Meckel's. Excision requires specific margins. A broad-based diverticulum cannot just be amputated and tied off. The surgeon must perform a wedge excision or a complete segmental bowel resection to ensure absolutely no ectopic tissue is left behind. A minor error in fetal development manifests decades later, requiring the surgeon to recognize and eliminate a precise anatomical decoy. Chronic infective pathologies also target specific zones of the bowel. Intestinal tuberculosis predominantly localizes in the terminal ileum and the surrounding cecal region. It manifests in two distinct forms. Ulcerative tuberculosis usually develops secondary to an active pulmonary infection, creating multiple transverse ulcers across the wall of the terminal ileum. This ulcerative form responds to anti-tuberculosis chemotherapy. Operative intervention is strictly reserved for catastrophic complications, like a complete mechanical obstruction or a free perforation of the ulcer into the abdominal cavity. Hyperplastic tuberculosis presents differently. In patients with higher immune resistance, the infection takes root in the lymphoid follicles. It generates a thickened fibrotic mass that closely mimics Crohn's disease or a primary cecal carcinoma. Because this fibrotic mass causes incomplete mechanical obstruction and is difficult to distinguish from cancer, an ileocecal resection is frequently required to remove the stricture and secure a definitive diagnosis. A different infective profile appears in patients with advanced HIV or AIDS. Opportunistic pathogens like cytomegalovirus and Mycobacterium avium intracellulare frequently colonize the weakened mucosal lining, causing severe enteritis. The surgical mandate for these opportunistic infections is restraint. Treatment must be driven by targeted antimicrobial therapy. Surgery is avoided unless the mechanical integrity of the bowel fails entirely. Neoplasia in the small bowel is incredibly rare, accounting for less than 10% of gastrointestinal cancers. Because the bowel is highly distensible, these tumors present late and are usually discovered only after they grow large enough to cause complete obstruction. Adenocarcinoma is the most common subtype. It typically arises in the jejunum and carries strong etiological links to Crohn's disease, celiac disease, and familial adenomatous polyposis. Removing this tumor requires a precise oncological clearance. The surgeon must resect the malignant mass along with a full 5-centimeter margin of healthy bowel on both sides, taking the corresponding wedge of the affected mesentery to clear the local lymph nodes. Neuroendocrine tumors, or NETs, pose a completely different pathological threat. They originate deep at the base of the intestinal crypts from specialized Kolchitsky cells. The danger of an NET lies in its biochemistry. These cells actively synthesize and secrete vasoactive peptides, predominantly large volumes of serotonin, directly into the bloodstream. If the tumor metastasizes to the liver and evades hepatic filtering, the circulating serotonin triggers carcinoid syndrome. The patient suffers profound facial flushing, explosive diarrhea, bronchospasm, and damage to right-sided heart valves. This hormonal payload dictates the surgical approach. Mechanical handling of the tumor during excision can trigger a massive fatal release of serotonin. To suppress this carcinoid crisis, patients must be placed under strict octreotide cover before the first incision is made. Successful small bowel oncology requires the surgeon to map the anatomical margins while simultaneously neutralizing the biochemical payload of the tumor's cellular origin. Whether resecting ischemic gangrene, an inflamed anomaly, or a malignant mass, the surgeon is left with severed bowel ends. The immediate mechanical challenge is safely managing those ends. Rejoining the bowel with a primary anastomosis requires two absolute physiological conditions. The two ends must approximate with zero mechanical tension, and the local arterial supply must be incredibly robust to heal the staple line. If the patient is hemodynamically unstable, or if the abdominal cavity is filled with profound peritoneal contamination or gross pus, the tissues will not heal. Attempting an anastomosis under these conditions guarantees a fatal leak. Instead, the surgeon creates an end ileostomy. The suffered terminal ileum is brought through the abdominal wall, diverting the fecal contents entirely away from the abdominal cavity. Small bowel effluent is highly caustic and loaded with digestive enzymes. By surgically everting the mucosa, folding it back on itself like a spout, the fluid is directed straight into an external appliance, preventing severe excoriation of the patient's skin. Diverting the bowel is a calculated tactical retreat. The surgeon sacrifices anatomical continuity in the short term to guarantee the patient's immediate survival. While aggressive resection is the only cure for ischemia and malignancy, the surgeon is constantly restricted by the finite length of the small intestine. Massive excision results in short bowel syndrome. Without sufficient mucosal surface area, the tract can no longer absorb the water, electrolytes, and macronutrients required to sustain biological life, forcing the patient onto permanent intravenous nutrition. Operating on the small intestine requires exact calculation. The surgeon balances the immediate eradication of lethal pathology against the permanent necessity of preserving absorptive surface area.